All right. Good morning, everyone, and welcome to the 2025 Empowering Health webinar series. This series will explore the intersection of health and technology, diving into the tools, challenges, and breakthroughs that are shaping how we care for ourselves and our communities. My name is Nerese Millette-Williams, and I am the project coordinator from the University of Maryland Extension Marylanders Online program. And this event is brought to you by the University of Maryland Extension, Marylanders Online, and in partnership with the College of Information and in collaboration with Family and Consumer Sciences. We have a great session planned for today, so we're so glad that you guys are here to be a part of it. Before we get started, I wanted to state that all university programs, activities, and facilities are available to all without regard to race, color, sex, gender identity or expression, sexual orientation, marital status, age, national origin, political affiliation, physical or mental disability, religion, protected veteran status, genetic information, personal appearance, or any other legally protected class. Additionally, please see the slide that includes QR codes for meeting the speakers, completing today's conference survey, and registering for the other webinar series that we have. You can also find these QR codes on our website and your program agenda. So I'm thrilled to kick off this session today. We're excited to be joined by Dr. Helen Hughes to discuss tackling social disparities in access and technology. Dr. Hughes is the medical director for Johns Hopkins Medicine Office of Telemedicine and Pediatric Telemedicine at Johns Hopkins Children's Center, as well as an associate professor of pediatrics at the Johns Hopkins University School of Medicine. A national leader in telemedicine and digital health technologies, she co-chairs the Johns Hopkins Patient Family Center Design MyChart Committee and has guided her team to win the AAMC Telehealth Equity Catalyst Award 3 years in a row. Dr. Hughes also serves on the American Telemedicine Association Clinician Council. It's an honor to have you here today with us. Please welcome Dr. Helen Hughes.
Excellent. Thanks so much. This is such an exciting series and excited to share some of our work. I'm happy to keep this informal in terms of questions, so feel free to either put questions in the chat or raise your hand or whatever question features we have, and we can kind of keep the conversation going. Is it okay if I take over this screen share? Perfect. Okay, excellent. My objectives here are to share a little bit about how we've had digital transformation at Hopkins during COVID, discuss some of the disparities in digital health access across populations in Baltimore, which I'm sure many are familiar with, but I can share some of our data, and also discuss some potential interventions for supporting older adults with electronic portal use and telemedicine access. Before I go too much into the details, I just wanted to tell a little bit of my background and story. I'm born and raised in Baltimore and was here for med school and all of my training. I work in the Harriet Lane Clinic at Hopkins, which is a clinic in East Baltimore, pediatric clinic. A lot of my patients have Medicaid as their insurance and have lots of barriers to getting to clinic appointments. And pre-COVID, around 2015, I had really gotten interested in telemedicine as an access point. I'd learned about the Indian Health Service and other groups that use telemedicine to help increase patient access. At the time, Maryland Medicaid only covered telemedicine if you were in certain originating sites like a health department or a school-based health center. And I was doing some programming to try to increase telemedicine access with a collaboration with an Eastern Shore Health Department, and also working on the Maryland Healthcare Commission school-based telehealth work group. Those times were kind of frustrating. We had a lot of logistical challenges, and I was honestly in January of 2020 thinking of kind of giving up on the telehealth dream. But then it was really breathtaking to see all these regulations change pretty much overnight in March of 2020 and see telehealth as kind of a viable way to provide outpatient care. At the same time, it was really hard to see that a lot of our platforms and technologies weren't as accessible as we'd hoped. And so some patients kind of being left behind in that evolution. So that's kind of the story I'm going to talk about today, but wanted you to kind of know about that in my background. So I'm the medical director of the Hopkins Office of Telemedicine. So we're kind of a central office that coordinates the deployment of all Johns Hopkins medicine programs, delivering virtual care tools, which is really healthcare at a distance over technology. We serve all 6 of our hospitals across 3 states and all of our ambulatory sites. And I have this really cool job where I get to work at the kind of nexus of IT, billing, compliance, legal, government affairs, and try to kind of connect the dots at a system level on how we deliver telemedicine. This is a snapshot, sorry, of kind of our transformation in one slide. So at the left, pre-COVID, we had a telemedicine office. We had these small pilot programs like the one I mentioned, but we were really only doing about 80 telemedicine visits a month, or 800 total. And then in March of 2020, with kind of the everything shutting down, we went up to 90,000 outpatient telemedicine visits by May of 2020. That was about 70% of our outpatient care. And then as things slowly opened back up, we hit a run rate of around 30,000 telemedicine visits a month. And here, blue is the monthly video-based telemedicine volume, and orange is our monthly audio-only or telephone. So now we've hit about 2.4 million telemedicine visits, and it's in terms of what percentage of outpatient care that represents, we're at, this is by specialty, by calendar year, so 2021 in blue all the way to the left, and 2024 in gray all the way to the right, what percentage of outpatient care in a department is by telemedicine. So you can see, certainly it's not a one-size-fits-all tool. All the way on the left, about 68% of our nutrition visits are by telemedicine, about half of our psychiatry visits. We have a few divisions and departments in red who've actually gone up in the past year in their amount of telemedicine: neurosurgery, neurology, genetics. You can't drive in the state of Maryland for 6 months after you've had a stroke or a seizure. So it's really hard for patients sometimes to get to neurology and neurosurgery appointments. And then across all of Johns Hopkins medicine, that's kind of in the middle, we're at 12% of our outpatient care. So I wanted to kind of summarize a little bit what I told as a story in the beginning of terms of, well, what are the telemedicine rules and why are we able to continue to provide this care, before kind of getting into the disparities in access. So what happened in March of 2020 that made telemedicine accessible for Medicare and Medicaid? It was all of a sudden permitted that patients could be at home in any location and providers could be at any location and do this care. Telephone was not covered pre-COVID, and telephone visits started being covered during COVID. It was expanded, the types of codes and the types of providers who could provide telemedicine. There was some flexibility as to the platform you could use, and there were some flexibilities about if you could provide care across state. And now we are kind of in a situation where, again, location is still flexible, telephone is still covered, provider types and CPT codes are still expanded. The platform has gone back to the pre-COVID state that it needs to be HIPAA compliant, which we think is a great thing. And then providers generally need to be licensed where the patient's located. But we're still at a pretty good place for being able to provide telemedicine care, and providers being able to bill for it. So as I mentioned early on, we saw that telemedicine kind of exploded overnight, but different populations were having challenge accessing it. We established a telemedicine equity work group across our School of Medicine, schools of nursing, and our some of our community affairs offices. We created a framework shown up here in the upper left with our Center for Health Equity on developing a telehealth equity dashboard, and we're able to publish and describe some of the disparities we're seeing. So this is a screenshot of our telemedicine equity dashboard about 2 years into COVID. It still exists and is updated daily, but on the top left, we looked at the percent of encounters that occurred via phone versus video. So you can see at the top at this point in time, we had about 1 million visits and 12% were by phone. And then we looked by demographic groups to understand in those groups, what percent of care was occurring via phone versus telemedicine. So the gray bars are the percent phone. We're going to go into the data a little bit more, but this is just showing you the dashboard at a high level. So we had race, ethnicity, preferred language, age, payer, and then we also had a heat map showing in any zip code, the percent of visits, encounters in that zip code that were by phone, with blue being 0% phone, so all video, and orange being dark orange being 50% phone. And so if you look at data from kind of the first 3 years of COVID, this shows in each group the percent of telemedicine visits that were by phone. higher percent telemedicine in patients who in our EHR were self-reported as Black or African American, higher percent telephone in older age groups, higher percent telephone in Spanish versus English speaking, and higher percent telephone in patients whose payer was Medicare and Medicaid versus only 7% in patients who had a private or commercial payer. And then looking at the zip code, we had kind of the black butterfly, white L pattern that is seen in other socioeconomic disparities in the city with higher percent telephone in East and West Baltimore. And certainly, kind of internet and device access or internet access is maybe thought of as a more rural health issue pre-COVID, but certainly seeing that, internet device access and digital skills leading to patients needing to use telephone more than video in these regions. And that becoming even more pronounced when you look at adults 65 plus, with seeing a number of zip codes where percent of telemedicine encounters were 50% or greater by phone. If you zoom into a particular geography, so this is looking near Johns Hopkins Hospital, Northeast Baltimore neighborhoods 21205 and 21215, which have a average median income around 40,000 and high percent Black and Hispanic residents in comparison to Roland Park with a higher income and a lower percentage of Black and Hispanic residents. We looked at in kind of those first 4 years after COVID, what was the percent of all telemedicine visits that, what was the percent of all outpatient encounters that happened by telemedicine? Really, actually, in the zip codes near Hopkins Hospital, more encounters happened by telemedicine than in Roland Park. But of those that occurred via telemedicine, a large percentage, around 37%, were by phone versus 9% in Roland Park. And then if you look ages 65 plus, those disparities were even more, with around the same amount of telemedicine use, but upwards of 52% of encounters occurring via phone versus 11% for adults age 65 plus in Roland Park. And then in terms of trends over time, some of these trends improved over time and some did not. Spanish language, that disparity did improve a lot over time. So blue here is 2020% of telemedicine visits by phone and yellow is 2023. Part of that is that some of our more predominantly Spanish-speaking clinics weren't open to patients who had COVID symptoms for the first couple of years and then started being open to patients with symptoms. So part of that is being able to come back in person more. The age disparities also decreased somewhat over time. The disparities by race decreased but persisted. And then the disparities by payer really didn't decrease very much, with a large percentage of the Medicaid visits occurring via telephone. So feel free to chat any questions if people have questions on this data or clarifications. I'm going to move to another topic, but the overall, this was helpful data into us kind of understanding these disparities and wanting to find some ways to intervene. Okay, so we've tried hard to make our telemedicine platform as accessible as possible. The platform we had that we went with initially at the beginning of COVID involved an app download. It was not a very easy to use platform. A few months into COVID, we switched to a different platform that did not involve an app download and would just be a link that you click. We also added interpreter integration directly into our platform and worked some with a person named Tony Davis at the North Carolina Department of Health and Human Services on some accessibility resources for deaf, hard of hearing, and deaf-blind patients and their providers. We were really excited and lucky to work closely with the AAMC. The Association of American Medical Colleges had a telehealth and healthcare equity working group, and we won some small grants to do a number of things. Our 2022 award was around hosting a session on digital health equity disparities in Baltimore City. Some on this call may have attended that. That was crazy to believe, I guess now 3 years ago, or 2 years ago, in the spring of 2022 or 2023. And then in 2023, we continued those convening sessions around some of our stakeholders in East Baltimore. And with 2024 award, we won funds to partner with Epic to develop kind of a pilot MyChart sandbox environment that we could help with digital literacy in both English and Spanish, and to take those resources into the community. Did you build the platform, or is it an Epic or other software platform? So I assume you're referring to the MyChart simulation piece. We worked with Epic. It is actually a web link, so it doesn't involve login or app download. It's a web link where you can click around and practice what it's like to be in MyChart with sort of a fake patient look. So definitely anyone who's interested in using it, I can connect you with the Epic team as we're currently piloting now, but I think their goal is to have it be publicly available. It's not Hopkins Epic, it's kind of generic MyChart Epic. It's filled in. Yep, I'm going to show you some screenshots, and I'm happy to walk through the link at the end here if we have time, for sure. So this is a summary of that event we had in June of 2023 in terms of some of the convening and some of the takeaways. We also worked with East Baltimore EBDI, who had a Microsoft project and did a community-based survey, indicating that community members in the East Baltimore zip codes near Hopkins Hospital were interested in more affordable internet service, targeted training that meets their needs, including how to use telehealth applications, free or low-cost computers, and more accessible Wi-Fi. And so in terms of our coalition building, would love to build more coalitions here for the groups that are here. We did work with a number of groups in East Baltimore to kind of think through options and grant options, which I'll talk about in a second, including the Baltimore City IT Group, the Baltimore Digital Equity Coalition, some local senior living facilities and churches. We've talked with Kennedy Krieger and Baltimore Medical System, also regionally in East Baltimore, Project Waves and Port Networks around access, NEMI Core around device access, and some of our local groups around digital skills training. And so now we have kind of a suite of 3 projects trying to address some of the disparities we saw on those dashboards. So right now we're doing the pilot of the MyChart training module that I mentioned, which I'll show a little bit more of. We also were excited, and I'll share a little bit more, to get a Baltimore City, Baltimore Civic Fund grant to take the training into 3 community senior living facilities. We're going to target adults age 60 plus in Latrobe, Parkview at Ashland, and Southern Baptist, and that has just started. And then we created a large grant to the National Telecommunications and Internet Administration that unfortunately likely will not continue, but that helped us discuss kind of what would be our dream vision for devices, internet, and digital skills in East Baltimore. So I'm going to share a little bit more with you about each of these 3. So we've been really excited through the AAMC funds to hire 2 community consultants. We have a community relations coordinator in our kind of research arm at Hopkins, and Barbara Bates Hopkins and Melanie Reese have been working with us as community consultants, helping us kind of co-develop some of this work. So they have been working with Michelle on my team, and Sumana, who's a preventive medicine resident, and Juliet, who's a social worker, who's doing a master's program with Molly Filler, who's a digital instruction designer at Epic, on the module that I'm going to show you in a second. And then we're going to take that module, and we have Tracy Chambers Thomas is helping to lead, along with our health education and training core, the in-community classes. And we've also been lucky to link with Lo Smith at BDEC, who's serving as a training consultant, helping us develop the materials. So I'll show more screenshots again in a second, but really this is a click-through online module giving individuals the ability to practice things like going to a menu, scheduling an appointment, looking at their test results, and ordering medications. The links will both be in English and Spanish. And right now we are piloting this with around 20 individuals to get feedback. Do the links work? Do they make sense? Do they have the right features? And so we should be wrapped up with this project in the next 1 to 2 months. And then this, I think I've kind of already mentioned around the Baltimore Civic Fund project, and we'll provide a few more details here. This is kind of a timeline of what we're doing. So, we are right now kind of in the pilot with patients in our transplant clinic and others, these links, making sure they work well. For the community digital skills classes, we've kind of hired our staff, and we just had our first class last week at Parkview at Ashland. And are really trying to work to make the classes as engaging and community member centered as possible. We've gotten a lot of good feedback. So far, some of the feedback we've gotten is, with these links. Initially, what we had with Epic was sort of like a lecture PowerPoint accompanying the links. We found that didn't work very well. It kind of felt too lecture-y. So we pivoted to a more scenario-based format where we give community members the scenario and then they kind of try it out themselves with the links. We found that we had too much jargon with wording like two-factor authentication. So we're trying to use AI software to help make sure we're eliminating jargon and using less technical language. And then we are struggling a little bit with the need to fundamentally review skills like logging in and two-factor authentication. Lo Smith is helping us with that, but it is a bit of a struggle to know how much to focus on basic digital skills versus how much to focus on kind of the health-related digital skills. And then this is kind of a 1.0 version of our flyer for the class, and we've gotten a lot of community member feedback from our consultants and others to try to make the flyers pop and try to get people interested at the 3 sites. So this is an example of what someone sees. There's a desktop link and there's a mobile link. So this is the desktop link. What happens is that, I don't know if anyone's ever played like Jeopardy in a PowerPoint, but when you do that, there's like buttons on the PowerPoint. So this is very similar to that when it's in the live environment, not in my PowerPoint. When you hover over this, you will see a little hand icon to be able to click it. But if you click other places, nothing will happen. So if, for instance, in the training, we're giving a scenario of, you are Rachel, the patient, and you're trying to see the details and check in and join your February 22nd video visit with Dr. Walker, the participant will be able to, either on a computer, iPad, or mobile phone, click the button view details, click the button test hardware, and see the test hardware features, click the button e-check-in, click the button join video visit, and click the button join call to kind of understand how those things look to get linked together. And they can't break anything or do anything wrong because all of this is kind of a simulated environment. Again, we held our first class last week with 5 people. The likelihood to recommend when they rated it was 4.4 out of 5. What went well were that we had a pretty high instructor to student ratio. So with 3 instructors and 5 students. So we had learners of really different levels. It was great to be able to give them a lot of one-on-one attention. We bought magnifying glasses, which was actually one of Lo Smith's recommendations because a lot of people, just have trouble seeing. And so that can be a barrier to being able to see things. The magnifying glasses were popular. And we felt with the high instructor to student ratio, we were able to have a range of skills levels. Some improvements to the class, we're trying to evaluate this, but the survey that we had was just too long and took too much of the time. So we have to make that more succinct. We thought we were going to be able to cover way more material than we did. So it took us about 45 minutes just to get through these links that had about 9 My Chart features highlighted. And then we need to decide about whether to do repeat session with the same participants. We'd initially envisioned kind of 1 session per participant, but I think that we're probably going to need to do more than 1 session per participant. So we'll kind of see how we do there. So I think now's a good time to pause for questions before we go to the next thing on the links. So I'm seeing interested in getting access to the links. Awesome. So I'm just going to put my email for anyone to email me, like to chat about the links, and I can just double check with Molly from Epic. But now that they have them posted, I'm sure they're happy to share them, especially if people are able to give feedback. Great. Okay. Yes. And happy to connect with any of you. I will just pause briefly and show the links if that's okay. Just because I think that'll be, let's see. And anyone who else has questions and wants to, oh, we're still working on the website. So good catch though, really engaged audience, which is awesome. If anyone wants to unmute and ask questions, please feel free to do so while I pull up the link. I will pull up the mobile link just so that the group can see that as well. So this is the example of the mobile link. Again, we gave the participants a scenario that they're a patient, Rachel Lynn, and the first thing they're going to do is log on. So the username and password is pre-populated. They can't actually fill this in, but they can know that they have to enter it and click login. Then the next skill is to go to the menu. So, especially for the patients with difficulty reading and low literacy, it's helpful to describe the items, the icons. So we described, going to the icon at the top left with 3 lines. And then they need to scroll down to see the second part of the menu. So they click on this orange bar. And the next activity was to go to the sharing hub and share their chart with their loved one. So they clicked sharing hub in the menu. And they selected they wanted to share their information with a family member, close friend, or caretaker. And then they wanted to manage ongoing access, which means we're going to give that family member proxy access. And they can select to invite someone and put in the name of the person they're inviting and select whether they want to give them full access or just scheduling access to their chart. Send the invitation. And then if they wanted to revoke it in the future, they could edit it. And then they needed to select the back button up here. And you can see how if I can't click anywhere else except for the things close and back that can take me back to the home screen. So it was really nice to do that together as a group in the session because people were excited to actually try it out, but they were also learning about the feature as they were doing it. So talking through, do I really want to give my daughter access to my full account? So it felt like a nice interactive way to kind of teach about what was available in my chart. Any other questions before I move to kind of my next topic? I think I'm going on the fast side, so I have plenty of time for the content.
How did you identify patients to join your education session?
So for the first one last week, one of our community consultants lives in that building. So she recruited 4 of her friends and she was one of the participants. So that was really nice because it felt kind of like a little bit of a safe space. And then we will be posting those flyers. We also have a liaison at each site who has said they can, talk to residents, promote the flyers, put the flyers in mailboxes, et cetera. And we're going to have our program coordinator do phone calls, hopefully with the participants beforehand to get a sense of, how many people have relatively strong skills and just want to use my chart versus how many people haven't turned on their computer and really may need more support.
Yeah, that makes perfect sense. Thank you.
Yeah. Any other questions? Okay, so the next I'm going to go into is sort of that big grant that we put together in the fall for the National Telecommunications and Internet Administration. It was a $12 million opportunity that I think unfortunately may not exist anymore. But the process we did kind of through thinking about the different resources we had and how we wanted to put them together, I thought was helpful. So I was going to share that with the group. So this proposal was aiming to build partnerships across digital equity-focused community organizations and healthcare systems in East Baltimore to create a national blueprint for how to integrate digital equity into healthcare and community ecosystems. So our partners each, we were kind of discussing how they each had strengths across silos. So in East Baltimore, we had Johns Hopkins. Johns Hopkins had a telemedicine equity working group with research expertise. We had an Office of Telemedicine and IT where we had kind of relationships with Epic. and MyChart training resources. We also had a group called Hopkins Community Connections, which had was not digital related at all, was an in-clinic social needs navigation group that was providing social needs support in clinic for patients, 5,000 patients per year at 15 clinics, including at 2 FQHC partners, with things like food pantries, housing, education resources, et cetera. And then we also have a community affair arms that already had a community-based health education classes, but those were not digital related. We also were working with Kennedy Krieger in East Baltimore that had a previous FCC grant to deploy 5G hotspots to patients, and they had a lot of lessons learned from that program, and are also on Epic as an electronic health record system and also use MyChart. Then we were working with Waves, which through Digital Harbor was working to provide free internet to over 3,000 households, already had a technical support line 24/7, and already had a partnership around digital navigators through AmeriCorps. And then we were working with NemiCorps, which already had a technical workforce development program around tech-related jobs, was already training community members in the tech field, including for device refurbishment, and already had wraparound social services to help employees who were doing device refurbishment and other technical related careers. And then finally, the Deutsch Foundation had experience in funding and scaling projects in Baltimore City on digital equity, and local and national CBO partnerships and funding experience. And so what we envisioned was the project was kind of taking these strengths and silos and integrating into them a holistic model that would have collaboration and connection, and have kind of more of a comprehensive person-centered digital equity intervention. So the first goal of the proposed project was to implement and evaluate 2 different models of connecting individuals and or households with community-based digital access resources. So on the left, we had a healthcare model where patients at these clinics across Hopkins, Kennedy Krieger, and 2 Baltimore Medical System FQHC would have an electronic connection between the clinic and the community organization through something called Find Help. Then our community-based organization, Waves and NEMI, would receive the patient through the electronic referral and set them up with 5G internet, a device, and some basic digital skills navigation. And then there would be electronic communication back to the clinic to say, this patient has been set up with kind of the basic tools. They can now have ongoing clinical navigation of things like MyChart and telemedicine after they've kind of gotten that foundational connection. We envision doing the same thing with the community sites, having these classes in the community, but using the electronic integration with Find Help to have our HEAT training core refer them to these community-based organizations, get set up with 5G internet devices and basic digital navigation skills, and then be re-referred back to be trained on healthcare equity, healthcare tech skills by the HEAT core group. As part of the project, we also had exploring kind of technology jobs pipeline and roadmap development for improving the internet infrastructure in East Baltimore, leveraging the strengths of the different groups, and then trying to describe this in such a way that other communities could replicate the process across healthcare and community. So it was a ton of work and also really exciting to kind of think about what it would look like to have $12 million to fund such an initiative. Unfortunately, it wasn't funded, but I think at least the discussions have hopefully helped us move forward to thinking about what it looks like to connect healthcare and community organizations around these digital skills, because it's quite complicated. So huge thanks to my team. Everything I showed here was the work of dozens of people. This is kind of the core Office of Telemedicine team that deployed all of those tools at the beginning of the pandemic. And I'm happy to take any more questions. Is anyone willing to unmute and speak to if they're doing anything similar? It sounds like we have some other people doing training programs.
Yeah, I am. My name's Rose. I'm from OHSU in Oregon. We have a digital health navigator program, and we work with patients who are scheduled for virtual visits and just need extra support getting their MyChart account activated. And so your sandbox would be incredibly helpful. We use Epic products and had just transitioned to EVC back in November. And so the web-based nature of EVC has been a bit complicated for patients with just all the browser permissions and whatnot. And then, as you mentioned, with the two-factor authentication, that one has also been a bit of a challenge. So just really neat to see the sandbox and that you can kind of work through some of those test scenarios with patients in real life.
Fantastic. I'm so glad you're on. Yeah, I think one of the WMC Tech winners was OHSU, maybe 2022 or 2023 around, because you guys, I think, had the like original sandbox, but it was actually built in Epic.
Yeah, exactly.
Is that correct?
Yeah, and it's also really confined to like in real life, like in person. And so
Yes.
it was on an iPad, and it did work well. It works well for like tabling events and community fairs and things like that. But we found through testing of what works best for the program that the one-on-one phone calls with patients are the most helpful. And so obviously that's not a real life scenario with it where they can use our sandbox.
Yes, totally makes sense. Yeah, I was always very impressed and jealous of your sandbox, but I couldn't get our teams, they didn't have enough bandwidth to do the work of creating and maintaining such a sandbox. So that's what's been really a game changer. And like actually in Canva, if anyone uses Canva, you can you can kind of make the buttons such that you could take screenshots of your own organizations, like if it's an internal non-public thing, and kind of make buttons so that the experience is see it, click it, go to the next screen, see it, click it, go to the next screen, without all the build required to have like an actual sandbox. But I'm happy to connect you to Molly Filler, who is, if you could email me just so that I remember, but I'm happy to connect you with Molly Filler, who we're working with, and I'm sure they'd be happy to have you try the links as well.
Oh, perfect. Thank you so much. And thank you for the session.
Yeah. How are you working with unsheltered populations of Hughes bearers? Yes, absolutely. So we haven't necessarily had that been a focus area of these trainings. I think if you go to the AAMC website and look at prior Tech Award winners, I think some of the other national groups, that was a focus area for them. This isn't necessarily something we are doing actively, but something we're advocating for. I think a historic barrier to some of this work on the healthcare side is the rules around inducement for government payers and not necessarily being able to give patients devices because of it potentially being an inducement. I know others nationally have had programs where they've given devices, but they've maybe for a compliance reason needed to lock the device to only use a patient portal. And I think it's hard to give away tablets that only use a patient portal because really the person needs to be using it for their life, for shopping, for watching entertainment, for banking, in order to also be comfortable using the device for healthcare. So there is an RFI out from CMS on decreasing regulatory burden. I'm happy to share it with anyone who's interested, but in our comments, we asked there to perhaps be clarified inducement rules around device and internet access such that health systems and or health plans could provide patients with tools. So that's a very roundabout way of answering your question. I think, in an ideal world, we could give patients the tools that they could use. It's just unfortunately more complicated than that, I think, right now. I don't know if anyone else has had a different experience. So that was a nice part of what we proposed around kind of this partnership model with the community-based organizations, because they would be the ones providing and maintaining the devices, which from an inducement standpoint and a just logistical standpoint was a better arrangement than us trying to provide devices ourselves as a healthcare organization.
Yeah, that could be really complicated. I totally get it. Yeah.
Thanks.
I miss the days of the phone booth and, kind of fixed communication, places where you can contact folks, especially those who are struggling.
Yes, and I think the Baltimore City IT and University of Maryland Medical System had a potential collaboration around libraries. The VA, if you like Google, VA telemedicine spots, I think have these pods at some places where people can come and have telemedicine visits. To me, it's really complicated for a number of reasons. One is you still have to get the patient the link. So if they go into just a computer in a library that's in a private space, they've got to know their MyChart username and password, and they've got to have an email address where someone could get them a link. So it's not as easy as just having the space. You still have to have the technical knowledge of someone there to kind of get them in. And then there are kind of medical legal type concerns of asking someone to come to a specific space for care where you maybe don't have the setup to do something in an emergency, as opposed to when they're at home, all of those legal issues kind of aren't possible. And obviously for unsheltered populations, that's even an additional challenge. But anyway, I think the idea of pods in public spaces for telemedicine sounds really good. I've personally felt like there are lots of challenges to that. And to me, getting someone a device that maybe has 5G, even though 5G isn't perfect, that they consistently know how to use and have, maybe is a better use of the resources, as opposed to physical physical pods in public places. But I'm totally happy to be overruled on that feeling.
I also noticed in working with the population, older population, some of them are more comfortable, interestingly enough, using AI. So kind of an in-between AI agent that could then access that technology for them with the password. They could have a voice command or something, or even, I don't know, that might get weird with the iris scan or whatever, or even a thumbprint, right? That can unlock the AI agent to then go forward. I'm just thinking of how I'm seeing people using AI. They're using it. Sometimes they're more advanced even than in use than the folks who are on the processing, consumer side.
I totally agree with you. And I think seeing patients who struggle with literacy, just basic reading, and trying to set up someone who struggles to read to use a computer with a mouse and a keyboard, as opposed to giving them a tablet where you could set up Face ID. If you think of the Apple products, which I think are often accessible. I know this is recorded. I'm not trying to give Apple a shout out, but they do have great accessibility features. So if you think of, you set up Face ID, you teach them how to say, "Hey Siri, do XYZ." You have the ability to do speech to text such that they can be read the text that's going. That's amazing. And it's going to be really much more accessible than trying to reinvent the wheel with something that's a lot more manual. I think MyChart doesn't yet have a button a text message has to be able to speak into it for sending a message to provider, but I hope they're going to get there in the next year or two. But I totally agree with you that I think AI opens up a whole new way to have the user interface just be verbally spoken speech, which could make it a lot more accessible. Great. Any other comments or questions? Wanda?
Yes, good morning. Oh, thank you for this presentation. Really interesting. I have a couple of questions. You have been mentioning about Baltimore, Johns Hopkins in Baltimore. Any plans in the future for suburban hospital? That's my first question. And I would like to suggest for the elderly population, I believe the trainings that AARP provides in the libraries that are in person, and they teach the elderly population to work on computers, and this is done by volunteers, and it's a very organic way to train. And for Hispanic population, the community health workers, we are really in contact with the population, and we have so many events during the week that maybe we can connect Hispanic population with this kind of technology. So I would like to suggest those because they will be really helpful.
That's
you.
fantastic. Yeah. Thank you so much. So yeah, if you could just email me, I just want to make sure I connect with Molly at Epic, but we have the links in Spanish. With Spanish My Chart. So we did take it to our Latino Family Advisory Board. And I think we had about 6 individuals there. About 3 of the 6 had used My Chart before, 3 of the 6 had not. It seemed like we got positive feedback that the ones who had used My Chart learned about new features that they hadn't known about before, and the ones who hadn't used My Chart were interested in trying after trying the link. So it does, I'm hoping, kind of take a little bit of the black boxness, out of it. As long as Epic's okay with sharing the links, I think it'd be great for, we could probably meet for just 30 minutes with community health workers to show them how to use the links.
Yes.
And we just use a QR code. So as long as the devices, you can either just type in the URL, or if you have devices that have a QR code, they can link to them.
Definitely. I don't know if you're aware, there's a coalition, a DMB community health worker coalition that it's trying to get all community health workers here in Maryland and Virginia working together as a unit.
Great.
So.
Awesome. I would love to connect. That sounds like
Okay.
a really, really great group.
Okay, thank you.
Yeah, thank you. Anything else? I really appreciate everyone's engagement. So I'm gonna, I didn't get a good job of writing down from the chat. So again, I'm gonna chat my email. If any individuals that are interested in connecting afterwards or working with the links, please email me and we'll take it from there. Really appreciate the invitation.
All right. Thank you so much for that fantastic presentation, Dr. Hughes. It was so many resources that I think is very valuable to our community. So thank you so much. We still have a little bit of time, so I just want to open it up for any final questions for Dr. Hughes. Feel free to unmute, raise your hand, or go ahead and type it in the chat. I'll give about another minute or so just in case. And as a reminder, you can find Dr. Hughes' information on our website or by scanning the code here, as well as her email as well. All right. If we do not have any more questions, I do want to say thank you again for such a thoughtful and engaging presentation, Dr. Hughes. And as we wrap up today's webinar, a heartfelt thank you to everyone who joined us today. Your energy, engagement, and commitment to advancing health, access, and technology is truly appreciated. Before we officially close, I just want to give out a few quick reminders. Continue learning about the future of health and technology by joining us for the Empowering Health webinar series. We do have a few more webinar sessions coming up, about 4 of them. And next week, our webinar session will be June 13th, 11 a.m. to 12 p.m. every week. It'll be on geographical disparities in health equity and access. So please feel free to join us for that. Also, you can get in touch with Marylanders Online by going to our website. We have on your agenda, there's a QR code on the second page to access all of our information. You can also feel free to give us send us an email or give us a call to our toll-free tech helpline. We are open from Monday through Friday, 10 a.m. to 8 p.m. and on Saturday from 10 a.m. to 5 p.m. Also, our program is on all social media, including Facebook, Instagram, and LinkedIn. And you can also sign up for our newsletter to see other conferences, events, and webinars that are coming up. So please have a look out for our follow-up email from Marylanders Online and complete our survey, which you can find on this slide by scanning the QR code. And it'll also be on the follow-up email. We'll appreciate any insights you guys can provide to us. Also, permission was given by Dr. Hughes to make this public, so this will be on YouTube as well. So we hope you leave today feeling more informed and inspired. Take care, and we look forward to seeing you guys at the next session. Thank you, everyone.
Thank you for organizing. Have a great day.
You too.